ठीक है. Okay.
Yeah.
Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along and they will be addressed. I'm honored to introduce our mentor for today, Dr. Akhtar. Dr. Akhtar is the Senior Clinical Fellow in Obstetrics and Gynecology in Kingston Hospital, London. Before serving in this role, she was working as a Senior Specialist in Corniche Hospital in Abu Dhabi. Her main interests within her field are high-risk pregnancy management, maternal medicine, and fetal medicine. And now it is my honor to request Dr. Akhtar to begin today's session. Thank you.
Hello, everyone. Thank you, Manahil, for the introduction. I'm just going to straight to my, to share my screen. Yeah. As Manahil told you, my name is Akhtar. Currently, I'm working in London. First, I will tell you about myself. I'm actually from Pakistan, from Islamabad. I did my initial training from Islamabad, and then I did from my MBBS from Army Rawalpindi Medical University. And then I got internship in internal medicine and obstetric and gynae. And after that, I decided to do obs and gynae. There are many reasons. One of them was I feel more comfortable with dealing with the women and the pregnant ladies. Secondly, during my internship, I saw many old women and they are coming with with prolapse, with so many urinary complaints and all this, and over the years they are not coming to the hospital because they don't want to go to any male doctor. So which I find that it's really important to work for the women. So that's why I decided to do the obs and gynae. So after this in Pakistan is actually you do the part 1, which is FCPS, before they will give you the training post. So I did the FCPS, and then I got a training also from Islamabad, from one of the tertiary hospital. And after completing, I did MCPS, and then I did MRCOG from Royal College of Obs and Gynae. As Manahil told you, I worked actually 11 years in UAE, in both in Abu Dhabi and Dubai, in different hospitals. I had a very wonderful experience, I got more, experience in obstetrics, and it's actually I developed skilled in obstetric medicine and fetal medicine, and also in colposcopy. And since 1 year, I'm here in UK because of my family reason, and also it's a good place, and also it's for the youngsters. It's good for the learning opportunities here. I saw and there is a proper training system here. Today, I choose the topic early pregnancy because I saw everywhere in hospitals and everything is the person who is, see all these early pregnancy changes. These are the most junior doctors and the trainees or the interns. So I thought just to highlight the important, problems in early pregnancy, just to familiarize you, all of you. At any point, if you have any question, you can stop me, or at the end, we can have a question answer session. So in early pregnancy, basically these 3 problems I thought I will discuss with you. One of them is miscarriages, ectopic pregnancy, nausea, vomiting of pregnancy. Okay. So first of all, what is miscarriage? So we have to define what is miscarriage. So it is a pregnancy loss at less than 20 weeks of gestation or 24-week gestation, depending upon the age of viability. Here we consider 24 weeks. In US, I think they are considering 20 weeks. Then also miscarriages are divided into 2, whether early miscarriages, which is in first 3 months, or from 13 to 24 weeks is a late miscarriage. It's because we divide them because there are different causes for both. A quarter of the women is actually presented with miscarriages. So it's quite, a large number of the women we see in early pregnancy with this problem. And basically the miscarriages, they are divided on different, classified in differently depending upon their clinical features and ultrasound features. So whenever the woman comes with vaginal bleeding in pregnancy, can anyone tell me that anyone is working or is a fourth year or final year student? Anyone can explain me what are the important things when a woman presents with vaginal bleeding in early pregnancy? You have to ask the patient what are the history you will ask, or what are the examination finding. Anyone? Okay, so basically, whenever the woman comes, in E&E or emergency or early pregnancy units with the bleeding, so first of all, you have to ask the women about bleeding. You take a detailed history about the bleeding, whether it's just a spotting, it's a heavy bleeding, or whether she's passing the clots, did she pass any pregnancy products, to assess the situation, of course. And then you also have to ask how many weeks she's pregnant. Let me see. Okay, yeah. Then you will ask other symptoms like any pain, any symptom of shock. Sometimes they feel dizzy, they have shoulder tip pain, so many other things. So to assess the severity of the bleeding and severity of the patient's condition, so you have to take a detailed history. Then the woman comes, then you will examine. So the first of all, the clinical examination is always you check their pulse, your blood pressure, you will clinically assess how they look, general physical examination, and then the specific examination, because that differentiate whether this woman is stable or not stable. And depending upon that, you will, further management is put in place. Because sometimes they are unstable because they have a very excessive bleeding or some other reason. So if there is sign of pallor, tachycardia, tachypnea, hypotension, so that's why I always put the code, or you will ask for extra help, so to resuscitate the woman. Then examination, you examine basically the abdominal examination, whether any tenderness or anything, any blood in the in the tummy. Then according to you have to assess. The speculum examination is very important. You have to look, you will see, first of all, that will assess you can assess the bleeding. If the patient is bleeding excessively, you can see, and if she's passing clots, you can see them sometimes of conception, you can see in the vagina, cervix is open or closed. All this you can assess on the speculum examination. And similarly, you will do the bimanual examination to see how big is the size of the uterus, what is you check the fundus, furnaces, whether there is any tenderness for ectopic and other things. And then, it is not moving. Yeah. Then, whenever woman comes with vaginal bleeding, you have a differential diagnosis. First of all, miscarriage is very common, a quarter of the women. The other is ectopic pregnancy, or it's a molar pregnancy, or very rarely a cervical or uterine malignancy. So this you can see the normal pregnancies in the uterus, and ectopic pregnancies, when it is outside the uterus, it can be in the fallopian tube, which is the commonest place, or ovarian or interstitial, or very rarely in the cervix. What are the investigations we have to do when the woman comes with the bleeding in early pregnancy? The one is, you can say as a gold standard, is that first of all, you have to confirm. The patient can give you the history that she did a pregnancy test at home, or she had ultrasound before or anything. If she just comes first time with the bleeding, then you can do the scan. And many units, they have an early pregnancy assessment unit where they have the radiographer or the doctors appointed to do the scan and then manage. So you do the scan. The scan is with ultrasound scan, it is transvaginal or transabdominal. In early pregnancy, you use a transvaginal scan, which we are using. And when we and see if we can see the pregnancy inside the uterus, and then we see the viable intrauterine pregnancy. live pregnancy, that's reassuring for the patient and for us also. If it's not alive, then you see whether in the uterus or the pole you can see, and if it is less than 7 millimeters, then you can rescan in 1 week. Or if it is, there is only the sac is seen, there is no fetal pole, then you measure the, mean diameter, sac diameter. If it is less than 25, that means that's an early pregnancy, you have to repeat a scan. If more than 25 millimeters and you can't see anything, no heartbeat, no fetal pole, that means it's confirmed missed abortion. In the night time, at many places, facilities available. So if the woman would come with just spotting or early bleeding, then you just clinically assess and you do the beta HCG, because it may be an early pregnancy, and unless the beta HCG level is 1500, you can't see anything on the scan. So if the beta HCG is like less than 1500, so you can arrange, another blood test after 48 hours, or you can, admit, depending upon after she's in severe pain, depending upon the clinical condition. Other investigation, which is very important, is blood group, because if they are Rh negative and they're more than 12 weeks, they need NTT injections. If they are pyrexial, then they have fever or anything, you are thinking of septic abortion, then you have to do the swabs, blood cultures, CRP, you have to admit them. What are the causes of miscarriages? Commonly we see with is abnormal embryo. Most of the women, when they come with a miscarriage or after the miscarriage, they're really stressed and they want to know what's the reason. So if it's a first miscarriage or second miscarriage, you can just reassure them that it's just an embryo problem, and it's not a problem with any of the partner or the female or the male. It is because of the combination is not the right combination, and it leads to miscarriage, and that's why it is very common. There may be different chromosomal abnormalities like trisomies, polyploidies, monosomy, and so many. There are so many. The other are hostile maternal environment where the uterus is not the right, which is maybe congenital abnormalities of the uterus, which may be a uterus diadelphys, or there may be a septum in the uterus, or there may be fibroids or adhesions, so they all can cause. But usually these causes a second trimester miscarriages, not the first trimester miscarriages. Other are infections. There are different infections like bacterial vaginosis, toxoplasmosis, listeriosis, and chlamydia and gonorrhea. Maternal conditions like poorly controlled diabetes, there is strong association with that. And then immune dysfunction, which is like antiphospholipid syndromes, thyroid autoimmune immunity, and they all are responsible for miscarriages. Progesterone deficiency, which is actually rare, but it can cause, or hypothyroidism or hyperthyroidism. Now I will briefly describe you what is threatened miscarriage, what is missed abortion, what is inevitable abortion, what is incomplete abortion, and then what are their management. The most important, the threatened abortion, is that it's a viable pregnancy. So you must have to understand that the women can come with the vaginal bleeding. The bleeding can be mild, moderate, or severe, but the cervical os is closed. And on this scan, you will see a viable intrauterine pregnancy. The different management options are, treatment options for threatened miscarriages. Whether bed rest has any role? No. The evidence does not recommend this one. Actually, the bed rest will increase the thromboembolic events. Uterine muscle relaxant, the Cochrane review concluded that it is insufficient evidence to support their use. Similarly, the role of FRCOG, which has a progesterone. Progesterone, one is natural progesterone, and then one is modified progesterone. On the is availability the progesterone, available progesterone. Because the progesterone is initially produces from the corpus luteum, neuronal placenta will take over. So if you give them mifepristone, which is anti-progesterone, it can lead to miscarriage. One second. Can you hear me? One second. I think we're.
Yes, we can hear
Are
you.
you people?
Yes, we can hear
I
you.
don't know whether it's working or not. Okay, thank you. So next comes the missed abortion. I do one second here. Missed abortion is, in other terms, like we say stillbirth after 24 weeks. So it's like the pregnancy stopped growing. So it failed at any point. So there are three options. Like one of them is that it was a viable pregnancy, and after 1 week we repeated the scan and we found that there's no heartbeat, so it's a missed abortion. Earlier I described that some women would come with brownish discharge or some mild bleeding, and you did a CRL and it is less than 7 millimeter. You repeat it after 1 week and it's still the same, so that means it's a missed abortion. Other diagnosis you make with the gestational sac, if you have just spotting or bleeding, you did a scan and the sac is like 30 millimeter or 35 millimeter, because the cutoff is 25 millimeters. If above 25 millimeters, you cannot see any fetal port, we consider as a missed abortion. Then again, we discuss with the women about options. One of them is conservative, medical, and surgical. So if we leave it for 4 weeks, there's a possibility that naturally they can pass the products. The advantage is that of the conservative is that they can go home. There's no side effect of the medication, no anesthesia, no surgical risk. Disadvantage is that it's unpredictable. They may miscarriage completely. They may have an incomplete miscarriage. They have to go under the procedure again, or they may have heavy bleeding. It can be in the middle of the night, so they have to come in as in an ambulance and as an emergency, and then it takes 3 to 4 weeks. So that's why some people, they don't like this one, this uncertainty or unpredictability, and they have other commitments also, so they want to do a definitive treatment. And then once they miscarry, then we have to repeat the beta HCG or a urine pregnancy test they can do at home after 3 weeks. If the woman is bleeding heavily or infection, or there is hemodynamic instability, of course, we can't do the conservative management. Medical management is we are giving mifepristone and misoprostol, and usually they take mifepristone 24 to 48 hours prior to the administration of misoprostol, and there's different guidelines actually, and it is about gestation less than 12 weeks and more than 12 weeks, and then again after the medication we give all these painkillers and misoprostol. They take at home, and it is 90% of the women's medical management enough, but in 10% of the cases they need surgical treatment. Either they comes with heavy bleeding, or it's incomplete miscarriage, or it did not work, so in that condition they need surgical treatment. For them also, we tell them to repeat the pregnancy test after 3 weeks, so just to make sure that it is it's negative, or if it's persistent, then you consider other things also. Surgical is some of the women, they are, if they are unstable or they have a bleeding or infection, or the woman's choice that she wants surgical treatment, because surgical treatment is one-time procedure, so the same day they can go home. So we discuss with them. We do suction curettage. We are giving them some, misoprostol prior to the surgical administration to ripen the cervix. And usually we prefer suction catheter, suction evacuation, because that is less traumatic to the uterus. Because with the curettage, there is formation of adhesions, and we can damage the uterus. That's most women, they prefer, because planned procedures, and then of course the risk of anesthesia, infection, endometritis, and 5 out of 1,000 women, they may have a uterine perforation, and in that they need an extra procedure like laparoscopically to repair that damage. Or if when they do the uterine perforation, if there is damage to the bladder or bowel, so we have to explain to the women all these things. This is the exam, you can see that how the suction, this is actually an outpatient suction. So if woman comes, os is open, they can just, with this suction catheter, they can just suck it. Then comes the recurrent miscarriages. So what is recurrent miscarriages? So from the name, you know that they have again and again repeated miscarriages. This is the definition is actually different. In UK, we say 3 or more consecutive pregnancy losses. In USA, they said 2 or more pregnancy losses. European Society for Human Reproductive Embryology also, say 2 or more pregnancy losses. Impacting one, it's depend in different this one, but on average they said that 1% of the miscarriages are recurrent pregnancy losses, and ASHRAE says 1 to 3% of the women of the reproductive age trying to conceive, they have actually recurrent pregnancy losses. What are the causes? So the most important is always we say that it's maternal age, but it is both maternal and paternal age. It's important. If the woman has previously miscarriages, that also is responsible. Then environmental factors, smoking has a very important role, and not only the active smoking, the passive smoking also has increases the risk of miscarriages. Psychological factor, those on psychological stresses and all this, they also have a more chances of miscarriages. Genetic, then anatomical, we discussed earlier that like uterine abnormalities, endocrine also, like hypothyroidism or diabetes and other metabolic diseases, infections, immune factor, the most important, and thrombophilia, the most important is antiphospholipid syndrome. It's not only always we blame the women's, the male also, there are factors which is responsible for that. Half of the cases we don't know the reason. So what is the treatment options? So 50% we don't know the reason. So the others, if we find the cause, then we have to treat that one. And the single, which is the most effective, the treatment is available is for antiphospholipid syndrome. It is both heparin and aspirin that it increases the live pregnancy rate to 75%. Usually we start, a recommendation is to just give them aspirin and heparin only for first 3 months. But if they have other risk factors, like of clotting and other things, or there's a risk of preeclampsia or IUD, then continue to through out of the pregnancy, the heparin, and then 6 weeks postnatally. And similarly, the aspirin also will continue. Antibiotics, if we find bacterial vaginosis, one of the responsible for that. If it is, we found that, then we can give clindamycin, which is 100 milligram vaginal ovules daily for 3 days. There is supportive role. They said the folic acid, of course, if they're having this maternal diseases like epilepsy or something, so we give the folic acid, and the recommended dose in that is 5 milligram of folic acid. Surgeries are actually not a bigger role, but if someone has a repeated miscarriages, and it is, you can see on the that it is just because of the uterine septums, and then we can offer the uterine septum resection. How much it is improve their pregnancy, it's difficult to say. And similarly, but if there is a submucosal fibroid and which is occupying and it leads to the late term miscarriages, in that we can do the myomectomy, or if there's a ring which is responsible for miscarriages, then hysteroscopic lysis of intrauterine adhesion is beneficial. Progesterone definitely has a role in recurrent miscarriages, and most of the women, as soon as they get pregnant, we start on the progesterone. We use cyclogest, which is 200 milligram twice a day. Usually we recommend till 13 weeks, but we can up till 20 weeks. They said that whenever the woman presented with a clinical diagnosis of the recurrent miscarriages, 3 or more, there's a reduction in the rate of miscarriages with the dydrogesterone. This is actually Hassas 2013 reference about this. Take-home messages that we should, any woman, because it's really stressful when you see those couples, they really, they fear to conceive again because of the risk of miscarriages. So they need psychological support, and then whenever they have 2 consecutive miscarriages, we should inform the patient and we should send for the investigation. This is actually the data analysis shows that you can give oral dydrogesterone up till 12 weeks, and from 14 to 20 weeks, you give vaginal progesterone. But again, it is different to different places. We are giving progesterone, vaginal progesterone for all women and all gestations, nothing related to that. This is just a brief summary. So threatened miscarriages, the woman comes with the bleeding, you see the cervix is closed. On the scan, you see it's a viable pregnancy. You observe, if it's a heavy bleeding, just you observe for admission for observation. If bleeding is mild, they can be discharged and referred back to the GP or midwife here. If more than 12 weeks, then you will recommend them NTT injections. Inevitable mean, from the name, you know that inevitable mean that it will not, the pregnancy will not continue. They may come with heavy bleeding, with the clots, and you see that the products are in the cervix. So this pregnancy will not go further. So they need evacuation, or maybe expectant, or conservatively that they will expel by themselves, or they need a surgical treatment depending upon how they're bleeding and everything. Missed abortion, we discussed earlier, that just a brief that what is miscarriage. On the scan, you know that no fetal heart, before there was a fetal heart. CRL is cut off is 7 millimeters, just remember that. Or sac size is more than 25 millimeters. Management is conservative, medical, and surgical. Incomplete, they come, they brought with some products, and then you see the still os is open, and on the scan you see if the product of consumption is more than 15 millimeters. So that means that they have a RPOC. So you discuss with them and be expecting stable, or they can have a medical management. And if they are more than 12 weeks, then they need NTT. Sorry, I don't know where is what happened. 1 second, let me go. Yeah. So next is ectopic pregnancy. So ectopic pregnancy, whenever normally 99% of the pregnancies are inside the uterus. 1% of the pregnancies, they are outside of the uterus, and which is life-threatening for the mom, the rupture. So it's really important to diagnose the ectopic pregnancy. Commonly, they've found in the fallopian tube and rarely in abdominal cavity, ovary, other places. Normally, you know that ovulation take place at the femoral end of them, and this one. And during, if any problem in the migration of that fertilized ovum will lead to the ectopic pregnancy. How they present, so they just may present, in the early pregnancy unit or A&E. If you are sitting, then they will just come with a history of amenorrhea, or maybe they did a pregnancy test at home with abdominal pain or shoulder tip pain, depending upon what stage they are or how they are clinically stable or unstable. Because if ectopic pregnancy is ruptured, then they may sometimes come in a shock, and nobody knows that. When you are clinically assess them, then you know that there's a blood in the tummy, and then when you do the for laparotomy or something, then they found that it is ectopic, and patients also not aware of that. So they may come in different situations. So again, depending upon of that, you can assess. Diagnosis is whenever in early pregnancy unit an emergency woman comes with small bleeding, and then you do the beta HCG, and the beta HCG is less than 1500. So of course you can't see anything on the scan, and she's stable, she can go home, and you can repeat the beta HCG. In a live pregnancy, the beta HCG should be roughly, we say double, but it is 66% increase. And if it's a non-viable pregnancy, usually it's a missed abortion, the beta HCG go down. So, or in ectopic pregnancy, usually the beta HCG plateauing, or it is slightly increased, less than 66%. And when you do the scan, that is confirmatory, that with the scan, if you can't see anything in the uterus, and you see an ectopic pregnancy, either can be a live ectopic pregnancy on the right or left adenexa, or you can see a just sac there. So you can clinically correlate her clinical picture, ultrasound, beta HCG level. What are the risk factors? So we know that ectopic happens because there is a problem in the migration of that fertilized ovum in the tube. So if there's a previous ectopic, then there's increased risk because we know the tubes are not right. PID also affect the motility of the tubes. IUCD, also the progesterone will slow the mobility. Previous surgeries, like, they have a, cesarean section or tubal surgery, all these adherence will affect the motility. Infertile couple, there is more ectopic pregnancy. And those who are going with the IVF and all this, because when they do the embryo transfer, there's a chance that it can, migrate, and it can lead to progesterone only contraceptive pill. That also is related to the motility. Smokers, they said there's association and increased maternal age. Management, how you manage expectant, medical and surgical, and depending upon the clinical condition also. If the patient is stable, you discuss all the three management. Expectant is that if the woman is clinically stable, there's no symptom other than the pregnancy, we don't know where it is, and beta HCG is less than 1500, so and it's declining, and ectopic mass is less than 3 centimeters. You see an ectopic is outside in Etinexa. No fetal cardiac activity, nothing in the, there is no free fluid in the pouch of Douglas. That means there is no, it's not rupturing ectopic. And patient is happy to go for expectant and happy to come back. They are ready to follow up, because it's really important that it may rupture, so then it can compromise the mother health. So what you do is you do a twice weekly initially the beta HCG, and you see there's a 50% reduction in the beta HCG from the initial level within 7 days. Then what you can do is then you do weekly till it becomes 20, which is the lowest level. You do transvaginal scan after a week and see whether the size was less than 3 centimeters. Now how it is. It is regressing, then it is also reassuring. And you have to tell the patients the red flags, like if they have severe pain, shoulder tip pain. Shoulder tip pain usually happens when there's a blood in the tummy and it irritates the diaphragm. So they got usually the shoulder tip pain, or they feel dizzy, which is mean that they are going towards a shock. So in that situation, and there should be somebody with them at home to bring them or call the ambulance. Methotrexate, the second option is methotrexate. Methotrexate is like, that's an anti-cancerous medication, is actually folate antagonist, and it is it's used and is really effective. 9 out of 10 women's, it is methotrexate is successful if we use the right criteria. Is usually we give a single injection, but we can have more than one injection. There's a largest study was done, and in there they recruited 559 women, and they said the methotrexate success was 90.7. And it is those, if we, in this way, we can save the tube. We have to tell the woman is that what are the, first of all, giving what are the side effects of the medication, that because it's an anti-cancer medication, it can cause nausea, vomiting. They should avoid the sunlight exposure because it causes photosensitivity, avoidance of alcohol, avoidance of NSAIDs, and they should have a good fluid intake because it has the effect on the liver and the kidneys. They should avoid the sexual intercourse because it can, lead to rupture of the ectopic. And they should use, because it's a teratogenic, so the women should avoid pregnancy for 3 months. Really, it can cause bone suppression. Usually, we just give 1 injection, so it's not that much. And alopecia also, you have to explain, as you know, it's an anti-cancerous medication. When the women agree for that, you do a baseline test, which is including the beta HCG level, urea electrolyte, liver function test, then FPC. Diagnosis, we know that we only do for non-viable pregnancy of ectopic. If it's a live ectopic, we can't do this one. A woman is hemodynamically stable, there is or minimal symptom. Beta HCG level should be, the cutoff is at 3000, so it should be, and on the scan they see the ectopic mass should be less than 3.5 centimeter. There should be no free fluid in the pouch of Douglas, or very minimal. Okay, so if they have a pre-existing medical disorder and all this, then you have to have, that's why we do the baseline. So we know that what is the creatinine clearance, because it has an effect on the liver and the kidney function, and it is excreted through that. And then women agree for follow-up, because it's really important that we have to follow them up. If they are breastfeeding, so we should tell them to stop breastfeeding, or they should not give breastfeed after that. First of all, we give the methotrexate on the day 1, and then we repeat the beta-HCG on day 4. They slightly increase in the beta-HCG level on day 4 because of the effect of the methotrexate on the ectopic mass. Then on day 7, there should be a 15% reduction in the beta-HCG level. If it is less than that, then either you repeat for methotrexate, or you give a go for surgical management. If there is fall, then what you will do is that then we weekly we repeat the beta-HCG level till it becomes less than 20. Success, already we discussed, it's in majority of the cases they said 90%, but there's different rates. In some literature they said 65 to 94%. And again, you cannot predict, because if the beta-HCG on a lower level, the success is more. The beta-HCG is like more close to the 3,000, then success is less. The side effect of the medication, commonly you tell the patient with abdominal, which is very common. 2/3 of the women, they present with abdominal pain, and sometimes it is because it causes the tubal abortion. So they will come with severe pain and all this. Vaginal bleeding or spotting can happen, nausea, vomiting, or gastric reflux. And they may have fatigue, lightheadedness, or dizziness, photosensitivity, or sore mouth and throat, and sometimes alopecia or temporary hair loss. Surgical management. First of all, we consider surgical management in those cases where the woman is hemodynamically unstable. So there's no option to save the life of the woman. You have to go for surgical management. Then moderate or severe pain, and it's a live ectopic. If the beta-HCG is more than 3,000, or usually they said 5,000, but like above 3,000, we will consider surgical, depending upon the other features also. And with the woman, that she's not compliant, and she doesn't want to go for medical. Surgical management is laparoscopies. I think everywhere they are using, and then also whether to do self-injectomy and self-ingiotomy. So self-injectomy is that to remove the tube. Self-ingiotomy, they make a hole and just remove the ectopic. The RCOG recommends self-injectomy, because if even they remove the tube, the chance, if the other tube is normal, the chance of having a normal live pregnancy in the next pregnancy is same, but it increases if we just do the self-ingiotomy. There's increases chance of ectopic pregnancy in the same tube. Even you go for the expectant or methotrexate, 1 in 5 women still they need surgical treatment. If you go for self-ingiotomy, you may, possibility that you did not remove complete, the pregnancy product. So you repeat the beta-HCG after day 7, and if it is, and then weekly till it is negative, or in self-injectomy, that you send the tube for histopathology and it confirms that it's an ectopic pregnancy. Then you just repeat one pregnancy test after 3 weeks. The other common presentation of in the emergency or in early pregnancy unit is nausea and vomiting of pregnancy. 50 to 90% of the pregnant women, they get some extent of nausea and vomiting. Again, it depends upon people there. Some they having more, some having less. Typically, it start at 8 to 9 weeks, and then. And it is dependent upon the beta-HCG level. So as the beta-HCG level goes up, they having, and majority of them they have resolved after 16 weeks. Very rarely, sometimes they have beyond 20 weeks. The other term, which is hyperemesis gravidarum, which is extreme of nausea, vomiting, we say in other terms, which is incidence is less, which is 3 and 220 per 1,000. In that they have intense or intractable nausea and vomiting, which leads to women dehydrated, weight loss, muscle wasting, electrolyte imbalance, and metabolic disturbances. And when they have a lot of, excessive vomiting, they can't eat anything, so that leading to the nutritional deficiencies. So once they come with the dehydration, so they may sometimes present with the postural hypertension, ketosis. They may have they continuously spit, or they have excessive salivation. They may have weight loss. Sometimes they come and they tell us that they lost like 20 kg or 15 kg. So we have to look for what are the other reasons. So what are the risk factors for excessive vomiting? One of them is multiple gestation. If they have multiple babies, so the HCG level will be very, very high, and other is a trophoblastic disease in which the HCG level is very high. Some, they have more tendencies. Those who are having, increased BMI or big mums, they have, more tendency of nausea, vomiting. What are the complications? So the commonest complication, it's not commonest complication, but the commonly we found that they come dehydrated. They are nutritional deficiencies, vernix encephalopathy, electrolyte imbalance, which is hyponatremia, which itself can cause lethargy, seizure, and other problems. And then also reflux and called Melry-Vestia, which is like, because when they have excessive retching, it can cause, the acid can also damage the lower part of the esophagus, and they come presented with hyperemesis. So whenever they're having excessive nausea and vomiting in pregnancy, in early pregnancy, you also have to rule out other things, whether they have reflux esophagitis, or they may have peptic ulceration, they have may infections. So you ask for other things, whether they have diarrhea, whether they have any other associated symptom. Hepatitis. So sometimes I saw the women with hepatitis. It's actually a vicious cycle. So they may have hepatitis, and with that they present with the nausea and vomiting, or they may have a nausea and vomiting which affect their liver and their ALT and AST genes. But of course, with hepatitis, the ALT and AST is very, very high, but with effect of the vomiting, it's not that high with the dehydration. Hypercalcemia, or any sometime intracranial pressure due to any tumor, due to any other reason, meningitis. There's so many, so they may present with a fever and other things. So you have to look for other, sign and symptom. Whenever normally when they come with excessive vomiting, they cannot tolerate, so you admit them, you do the blood test, like what is the FPC, what is their urea electrolyte, the kidneys are functioning well or not, LFT, whether they have any other liver, whether they, how much is liver is affected, or whether because of the liver they have them hyperemesis. You check the urine, see how much is the ketonuria. Usually it is coming as +1, +2, +3, +4, so you can assess the dehydration level. UTI also can cause hyperemesis. And sometimes they are dehydrated, and that can also, leading to the thyroid function test. You do the ultrasound scan of the uterus to check, whether it's an intrauterine pregnancy. The woman is, is really distressed with nausea and vomiting. It's a single baby, or it's a multiple gestation, it's a hydrative hormone. So many things you can, or sometimes the torsion also, whether there's any ovarian cyst or anything, and also you will do the abdominal scan for liver and upper abdomen, and sometimes they have a gallstone. So many things you have to rule out. Management is, after checking their initial signs and symptom, weight is also very important whenever they presented, that you have to check, because if they have a weight loss, or you can, refer back and say presented again, then you can compare that. Clinically, physical examination, you see the sign of dehydration and sign of muscle wasting, and urine dipstick for infection and ketones, and usually we do for all them patient for the cultures. In our hospital, we use this PUQE, scoring. The total score is 24, and on that basis of that, we can, categorize and where to manage. So, if in the last 24 hours, how long have you been nauseated or sick to your stomach? So if not at all, is 1 hour or less, 2 to 3 hours, 3. So you have a score like, in the last 24 hours, have you vomited or thrown up? So you check with them, this is the scoring, you will see how much. So depending upon, you will categorize them as a mild, moderate, and severe. I think it came, yeah. So depending upon the scoring, so if the score is PUQE score is less than 7, so this woman is that can be managed with or just with antibiotics, and give Leffler to the patient and advise back have and her condition. If the 730, so if the score is more than 15, so then they will go directly to the ED, because we don't have the facility, because they need IV cannulas, fluid admission, and then we have to look for other effect, because that means the women is with hyperemesis. They have to rule out the reason of this hyperemesis, whether it's intracranial or they have
I don't know if Dr. Akhtar is able to hear this, but you aren't streaming anymore.
try to share my screen. Okay. Can you hear me?
Yes, we hear you now.
Okay, thank you so much. Yeah, so I'm on hyperemesis gravidarum. So what are the therapeutic aims? Of course, we know that they are dehydrated, so we have to correct the dehydration. We have to improve their symptom, and we have to break this cycle, actually. Fluid and electrolyte, sorry about that. Replacement. So what are the fluids we give? Usually we give ringer lactate or the Hartmann's and normal saline. Preferably we are avoiding the glucose carbohydrate rich fluid, vernix encephalopathy, and then of course antiemetics. And then we see the electrolyte levels, and depending upon the sodium and potassium, we replace the electrolytes. And we give actually regular potassium with ringer lactate, depending upon how much is deficient, and we replace that. And these women, they need admission, and they need to stay in the hospital. Usually we keep for 24 to 48 hours, and most of them, they get better with that. And then we can discharge on the oral tablets. Sometimes some of the women, they may have a multiple admission to the hospital, especially in the first 3 months of the pregnancy, till their HCG's level is stable, and then they are okay. We know that they can't eat anything, they can't tolerate anything, so they have nutritional deficiencies. We will encourage them to take small frequent feeds, and whatever is palatable to them, according to that. Timing is we also give them, which is 50 milligram 3 times a day. It's in tablet form or injection. And you actually in different places, I saw there's a different vitamins, and then looking at that one. Antiemetics, which antiemetic we the first is we use is cyclazine here. Initially, we give injections, which is 50 milligram IM 3 times a day, and then we can switch to oral. If that's not working, then we can give them prochlorperazine. This is in the suppository form, 25 milligram per rectal, and then the metoclopramide comes as a third line. There is also available nevidoxine or Zenova, which is doxylamine plus pyridoxine. And ondansetron, which is if very reluctant, cases where nothing is working, we give ondansetron, although we should avoid ondansetron in the first 3 months of pregnancy. Complementary therapies are, how much their role is very difficult to say, but some says that in some of the women, the ginger may be used that can help. Acostimulation, acupuncture, and acupressure, that's, in some of the women it works very well, and those who are really trained in that, they know what are the points on that. If they put the pressure, that helps in suppressing their vomitings. Similarly, hypnotic therapists, some of them they said, but should not be recommended as to manage just for nausea, vomiting, and hyperemesis gravidarum. As you know, that when they are dehydrated, there is and pregnancy is a thrombogenic state, so they are very, very high chance that they have a clotting in the legs, and risk of DVT, and that can, the women, if they go to the hospital, and they be put on TED-stocking and prophylaxis. If they are at home, they don't need it. Upon their BT score, we actually there's a scoring system in pregnancy, and according to that, their score needs so we refer because and especially if they more than 5 weight, then they should be referred to the so
Dr. Akhtar, can you hear us?
Yeah, now I can hear. I don't know how much presentation in between you missed, because it was disconnecting and then reconnecting again.
No worries.
It was, I think, yeah.
Let's see. We're on thrombo.
Really, your voice is not clear. It's just like hello.
You can try turning off your video.
Hello,
and you can
Manahel.
share your slides.
Can you hear me, Manahel?
Yes, I can hear you now. Can you hear me?
Oh, yes, I think, yeah. Yes. Okay. Yes, Manahel.
Okay, we screen shared your slide to thromboprophylaxis.
Mm-hmm. Thromboprophylaxis is that, all women with nausea and vomiting, they are very high risk for thrombosis. So if they are admitted to the hospital, definitely they need thromboprophylaxis in terms with the TED-stocking, and we will give the low molecular weight heparin, depending upon their weights. If they are at home, they don't need it as an outpatient cases. But if there is risk factors, we calculate there is a risk factor, a calculation, and if they need it, then we will give thromboprophylaxis throughout the pregnancy and postnatally. And other thing we discussed that we should refer all these ladies to the dietitian, because they can't tolerate anything, so they need a dietary referral. Hello? Yeah. So as we discussed, that dietitian referral is important in these women. And also, if any woman having a weight loss more than 5% in early pregnancy, then we have to send them to further diet. And usually they, depending upon, they discuss with them according to the weight, they recommended the, diet and other things. Thank you so much, everyone. I'm so sorry for my voice and so sorry for the, I think there was an internet imbalance or something. There was in between, it was disconnecting. So I was not sure that how many percent, slides you missed.
In no ways, Dr. Akhtar, we still really appreciate you taking your time out of your day to mentor us and teach us. We will now begin our Q&A session. So my name is Hamza. I'm a student in Seton Hill University and Lake Erie College of Osteopathic Medicine's BSDO program. To start off our Q&A, what are some causes of an ectopic pregnancy?
What are some causes of ectopic pregnancy?
Yes.
Can you repeat? Okay. So first of all, if we know the pathology that the ectopic pregnancy happened, because we know that fertilization happened at the fimbrial end of the fallopian tube, and then the fertilizer will move to the uterus. So anything which affect the motility of which affect the fallopian tube, in other terms, will lead to the ectopic pregnancy. So commonly we see that like those who are having pelvic inflammatory disease, infection, so that will affect that, the infection can lead to the cilia which are in the fallopian tube that affect that one. Or if the woman is having going for the fertility treatment. So we know that because their tubes are not patent or they are not, they are already affected, there's more chances in those who are having the progesterone, because progesterone slow down the motility. So if the woman having, on progesterone injections, or they take the progesterone in other terms, that will stop their this motility of the fertilized ovum. That can lead to, or any surgery on the fallopian tube, any surgery in the surrounding, like those having even ectopic, this appendicectomy. So these are adenions, and that affect the also the tubes motility, and that can damage the tubes, then can also lead to the ectopic pregnancy.
All right, thank you very much for the answer. Another question we have is, what determines high-risk pregnancy and how can we prevent it?
Can you type the question, because I can't, your voice I can't hear properly. I'm so sorry for that, but if you can type the question, because can you repeat maybe, because in between when I are talking I can't
right
hear
it may be
properly.
that I'm a little fast.
Voice is breaking.
What determines high-risk pregnancy and how can we prevent it?
Okay.
Question's also in the box.
So yeah, okay, that's fine. So pregnancy and how we can, pregnancy is a normal physiological condition, and most of the pregnancy they are low risk, and high risk is that it depends so many factors in the moms. One of them is that general age, high BMI, that she's obese, she has a medical condition like diabetes, high blood pressure, or she has other medical issues like which can affect the pregnancies, like they're epileptic or heart disease, any kind of medical condition like that. They are coming at this one. And then pregnancy itself, that the baby, we will see the fetus, they are more than one fetus, like single pregnancy or multiple pregnancy, twins or triplets or like that. And then the fetus is affected, a big baby or a small baby, then water on the baby, which is called polyhydramnios or oligohydramnios. The woman has infections, or woman has any surgeries before, like surgeries on the uterus, or surgeries of like previous surgery in the pregnancy, like previous sections. So there are so many, things. The patient has a psychiatric issues or psychiatric problems, and they are on so many medications. And then from placenta point of view, we see that the placenta is low lying, is a placenta previa, or in the pregnancy, they have repeated admissions, like in any pregnancy, they're admitted with a bleeding, or they have, repeated miscarriages. So all those things make them, high risk.
Right. Thank you very much for that answer as well. The next question that I have coming up, what is the most common genetic abnormality in pregnancy?
in what terms it is, like in terms to the babies, you mean, or what is
Likely towards the baby.
I think the commonly we rule out with the three syndromes, which is called Down syndrome, trisomy, Patau's, and Edward syndrome. So these are the three we are, seeing.
Thank you. And then this is a little related to that last question. Which tests usually need to be done to determine genetic disorders in the fetus? So, for example, Down syndromes or any other syndromes you mentioned.
Is in the babies, usually for these three syndromes, they will assess depending upon the three, how to, risk assessment they do, depending upon what's the mom's age. Then they do the nuchal translucency. They will do the scan of the baby around 13 weeks, 11 to 13 weeks, and they check a thickness behind the baby's neck, which is called nuchal translucency. And at the same time, they do the blood test. And there are different levels of alpha fetoprotein, beta HCG, and all this. And then the triple markers and all this. And then they determine what is their risk. So if their risk is high, that is, then they will do the, more confirmatory test, which is amniocentesis or chronic villus sampling. If it is in less than 13 weeks, then they will just do chronic villus sampling, which means that they will just take a tissue from the placenta and then they do the karyotyping, on that they will assess what is the, genetic sequence, and or they can do the amniocentesis, that is after 13 or 15 weeks onward. They just take a fluid from the babies, which is the fluid around the baby, send for that, and then they will analyze that, and then they can find out whether it's, what kind of syndrome it is. And then also they find out the genetic sequence. Now there is another test which is called NIPT or NIPT, which is actually, it's done on the mums, and on the mom's blood. And then from that, they will take the fetal, cell, and then they do the analysis on that. And they found out that whether there is, Down or not. And depending upon that, they will assess. But the confirmatory is chorionic villus sampling and amniocentesis.
Thank you very much for that answer as well. Now, regarding your day at work, what are the most challenging aspects of working in OBGYN?
What is the most challenging aspect of working in OB-GYN? I think everyone says is in obstetric, it's unpredictability. Sometimes the low-risk moms comes and they land into complications. So everything you cannot predict. I don't know, maybe it's all in the medicine, but like, especially in obstetric, it is says like that. And sometimes the high-risk women, and they do very well. And then I think maybe if you're really committed, it's a bit challenging in the long shifting hours. That's also like, I think, and these do, which I feel the most challenging is the timing and unpredictability in obstetrics.
Thank you very much. And now also for your day-to-day life. So can you walk us through a day in your life, as in what you do at work on a day-to-day basis?
Okay. Hello.
Yeah, hello.
Yeah, I really enjoy my work, and depends upon, we have shift duties, like we have a 9-week rota. So in that, we have like 1 week we have 4 nights, and then we have 3 offs, like Friday, Saturday, Sunday, and then we have the next week we have over the weekends 3 nights, and then the next week we have over the weekend 3 days. So 3 weeks we have busy, and then you have like, weekdays, like maybe 4 or 5 days you have to work, and 3 days you have off for the next, and then you do like different things. So you have to do the clinics, which is obstetric clinic, also like seeing the pregnant ladies, and also the gynecological, you see the gynae clinics. And then also you attend different theaters like gynae theater, so which is really, I enjoy the surgery, and you do different procedures and whatever you like. And then there is subspecialties in that actually, when you progress more. So if you like fetal medicine and maternal medicine, so you only do the scanning, and then in between you manage the pregnant ladies, or you do the labor ward. That's maybe once in a week, but most of the time you just do the scanning, you do the procedures related to the fetus only. So you will not do the gynae and other beds. Similarly, if you want to do the gynae, so you will do the urogynae. So all urological problems like prolapse and urinary symptoms and urgent incontinence and all this, you will just see. So whole of your week is split into theaters, like maybe 1 or 2 theaters or 1 or 2 clinics, and then one day you have to, everyone in UK, they have to do the labor ward. But in other part of the world, maybe in where I worked in UAE, the gynecologists are not doing the obstetrics, so they are only doing the gynae patients. So they have theaters and things like that, and weekends of course off. And then those who are working in obstetrics, they have to do the whole of the week, including the weekends also. Obstetric is more demanding compared to the gynae, which I feel. But you enjoy obstetrics also, of course, when you see the mom and baby, they are like after the delivery, and they're so thankful to you, and you see the the smile on their face. So that's really, you feel satisfied from inside.
Thank you very much for that answer. And for our last question, how do you manage your work-life balance?
Okay. Actually, I want to be, obstetrician, and so that's why I'm enjoying my work, and because I'm not feeling as my job. It's like if a week I'm off, so I will, I'm missing my work. So that's why I have time, because when my normal hours are like 8 to 5. So like my children now, they are big enough. They are like, in high schools and all this. So in the night, in the evening, we have together dinner and all this, and over the weekends we plan to go out or something. So I think I'm enjoying this one, but I know that I spend a lot of my time in UAE, where I have a good support, and the life is comfortable there. So that helped me to manage when my kids were very small. So maybe in UK you don't have that support here, but in other part of the world, like in my friends in Pakistan and in UAE, they have nannies and they have full-time maids, so then it becomes very easy. But I think all fields are the same. If you are a doctor, if you want to be a doctor, then you are committed, and then you are like you have to do that one. So I think without the work also, I think this is our like for us as an enjoyment and satisfaction and all this. So I'm here in this field, I think now more than 20 years. So like really, I never think that I can do anything else. And if I will get another chance, so still I wanted to be do medicine, and I want to do the obs and gynae. So.
Thank you very much, Dr. Akhtar. These are all the questions we have for today, and we really appreciate you taking the time to mentor us today. Okay. I'd love for everyone to please give a warm thank you to Dr. Akhtar in the chat box for this incredibly informative session. Thank you.
Welcome. Okay.
Now we're going to conduct. Oh, sorry. Go ahead, Dr. Akhtar.
Yes, tell me. Yeah. No, sorry. Maybe I missed something. Yeah.
No, that's all right. We were just going to conduct our closing session with our quiz and our future session dates. So the link to the quiz for the session is now live. You'll need a 70% or higher to pass and receive certification. And the link to the quiz is being sent in the chat now. And now for our next session dates, which will also be posted throughout our social media outlets. So be sure to follow us at TeleShadowing.
Thank you all for attending our full month of psychiatry sessions. Our next session will be next Saturday, December 17th at 10 a.m. Eastern Standard Time with a physician mentoring us in OBGYN. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.